Okay, so welcome everyone, welcome to all those online and welcome to those in the room to Liverpool Medical Institution. My name is Andrew Weeks, I'm president of the LMI for this year, and we've been running a program of lectures called Bringing Life, and people may have seen the program. It's available outside, or it's also online in the LMI website. And it's been a fantastic series of lectures. We've had 20, we're going to have 20 overall, and this is now number 19. So it seemed appropriate that we'd finish the lecture series with sort of big overviews of maternity care, both globally and then in the UK. In 3 weeks' time, we've got Alex Heasel coming, who's been part of the AMOS review to talk about the future of maternity care in the UK. But tonight I'm very happy to introduce my old friend Tina Lavender. So when I first arrived in Liverpool in 2003, were you still research midwife at that stage, I think?
Yeah.
Before then going off to be professor at UCLan, and then going on to Manchester, and finally we tempted her back to LSTM, and we're very happy to have you back here. So Tina has worked not only on midwifery care in the UK, but a lot of my involvement really has been on global midwifery, and so brings a unique perspective of both UK midwifery, but also global work with WHO as to how to enhance midwifery worldwide, and especially sub-Saharan Africa. So I'll stop wittering. Tina, thank you so much for coming tonight, and welcome. If people have got questions as we go ahead, just put them in the question and answer, or if you've got them, we'll take them from the room as well.
Okay.
Thank you, Tina.
Thank you, Andrew. And thank you all for coming, especially on this really lovely evening. And thank you for those of you who are online as well. So Andrew gave me this title, Strengthening Midwifery Globally. And that is just a huge topic that we couldn't possibly cover in 40 minutes. So I have narrowed it down a bit. I took poetic license, and I'm going to talk mainly about the importance of relational care, but I will touch on some other things as well. But I'll start off with the topic that I was given by Andrew, strengthening midwifery globally. And I'm sure that most people here know what the pillars are to enable a strong midwifery practice and workforce, which includes education and professional development, regulation, policy and strong leadership, adequate investment, good working conditions, collaborations and advocacy. And I will touch on some of these, but not all of these. So just to manage your expectations. I will touch on the safe and the supportive workplace, midwifery models of care, community engagement, promotion of evidence-based practice, and also leadership development. So just to acknowledge that the things that I say today are my views based on my research and also on my experiences. You may not always agree with what I say, and maybe that will lead to a nice discussion at the end. But normally when I give a lecture, the first question that people ask me is, where did my global health research journey begin? And it actually began at the Liverpool Women's Hospital. So as Andrew said, I was a midwife research coordinator, developed the first clinical midwifery research department, which some of you will have worked in. Just looking at Adiri and Carol. And I was working one day at the Women's Hospital, and I got a phone call from Sonia Henderson. So Sonia Henderson was the coordinator of the pregnancy and childbirth group of the Cochrane collaboration. And she phoned me and she said that there's a midwife from Tanzania who's actually doing a diploma in tropical nursing at the Liverpool School of Tropical Medicine. And she's desperate to talk to a UK midwife, and would I talk to her? So I said, yes, of course. So she came over to the Women's Hospital and we had a chat. And she said to me, would you come to Tanzania in a few months and give a talk at this conference? So I said, yeah, okay, fine. Never been to Tanzania before. Why not? And I got to the conference and there was probably about 2,000 midwives there, which wasn't what I was expecting. And one of the people that I actually met there was this lady, Professor Helen Legina. And Helen Legina was a professor of midwifery in Tanzania and was a really inspirational woman. And we went to dinner one night and she ordered a fish. She ordered a tilapia fish. And the man on the next table also ordered a tilapia fish. And when her fish came, it was the size of the one at the bottom. And when the man's fish came, it was the size of the one at the top. So she called over the waiter and she said, "Excuse me, what's my fish?" And he said, "It's tilapia." "And what's his fish?" "Well, that's tilapia as well." And she said, "So how much is mine?" So he said, $10. "And how much is his?" $10. So she picked up the plate, she gave it back and said, "Bring me the same size of his then." And then when he went, she turned around to me and she said, "Equality starts at the dinner plate. And without gender equality, you can't have health equality." And that really stuck in my mind. And I knew from that moment onwards that I was going to work with Helen Legina. And we did work quite a lot. We did a lot of capacity development and research projects. But unfortunately, she passed away prematurely, so we didn't reach our partnership potential. But we did develop the Legina African Midwives Research Network in her honour. And this was a network that was supported by the Tropical Health Education Trust, a network of midwives from 6 countries from sub-Saharan Africa. So that was Kenya, Malawi, Tanzania, Uganda, Zambia, and Zimbabwe. I normally miss one of them out, but I remembered. And the idea was that we would develop midwifery skills in evidence-based practice and research with the aim of improving maternal and newborn health. And as part of that process, we will also prioritise research areas. So this was our multi-country partnership capacity development programme. And what we did was we took 20 midwives from each of those countries, and the leader of those 20 midwives then buddied with a UK midwife, and we worked together through the research process. So we were learning and doing at the same time over a 2-year span. And the impact of that was phenomenal, not just in terms of capacity development, but also changes in practice. So just to give you a flavour of that, in Zimbabwe, they had an issue with physical abuse in labour, and that reduced from 23.9 to 6.8%. Still too high, but it came down. Assessment of caesarean section wounds wasn't happening. And from the research we did, it increased from 22% to 100%. In Tanzania, we changed systems to improve training and prevent delays in care. And in Zambia, we had improvements in adherence to standards aimed at reducing factors contributing to intrapartum stillbirths. In Uganda, we had a 70% increase in observing vaginal blood loss within 1 hour of birth. In Malawi, we introduced ambulance bikes to prevent delays in rural areas when women couldn't get to the facilities. And in Kenya, we improved postpartum hemorrhage management. So there was a 74% increase in women being given information and a 33% increase in catheters being inserted. So these were just small projects that had a big impact. So from this capacity development programme, which you can see at the top of this flowchart, we carried out a number of different activities, both in terms of research and audit, development of educational games, looking at obstetric fistula, HIV management, ICM competencies. We had a number of PhDs as well. and our later work has been on stillbirth and also respectful care. But wherever I've been across the globe talking to midwives, and midwives do like to talk, I've found that they've always been very compassionate and very dedicated and always wanted the best for women in their care. But I've also recognised, and I'm sure that the midwives here recognise this, that there are too few midwives to do the work that's required, and there are a lot of other things that midwives have to do on top of their core job, which make it difficult for them always to meet the needs of the women that they support. And there clearly isn't enough midwives. You only have to look at this map here, and you can see that the darker shades of orange only have between no midwives to 2 midwives per 10,000 population of midwives. And you can see where these dark colours are, compared to the UK, for example. And for every $1 invested in midwifery yields up to $16 in social and economic gains. So it's very short-sighted not to increase the number of midwives. So if we look at the countries that do have most nurses and midwives, and the reason why is sometimes people don't aggregate the data, and sometimes in some countries use nurses and midwives interchangeably. But you can see just rolling through this list that all of these countries are in high income settings, and you can see this even more clearly in the map. Where most nurses and midwives are actually in North America, Australia, and in Europe. So why we need more midwives, and this is probably obvious to everybody here, but just a few facts. Every 2 minutes, a woman dies from causes related to pregnancy or childbirth. Every 17 seconds, a baby dies before birth. Each year, 2.3 million newborns die within the first 28 days of life. Caesarean births are up nearly 30% worldwide, often without improving outcomes. And we know that there's disrespect and abuse, and there's unmet family planning needs, and this harms women's health and their rights. We also know, and the ICM have a big campaign about this, 1 million midwives could prevent 67% of maternal deaths, 64% of newborn deaths, and 65% of stillbirths by 2035, saving more than 4.3 million lives by 2035. So just think about that. That's a lot. So are more health workers the only answer? Well, I was privileged to be part of a research team that looked at this. And what we did was we used global data looking at the investment in midwife availability and the working environment. And what we actually found was that from the 98 countries that we looked at, we found that in the majority of them, more midwives did equal better outcomes. But there were several countries where more midwives didn't equal better outcomes. So what this actually says is it's a lot more complex than just having more numbers. There are more factors around this. And I think key to that enabling environment is clearly respectful and relational care. And I think this is something that we've overlooked over the years. So what do we mean by relational care? Well, relational or relationship-based care is a care where the woman is cared about as well as cared for, and where the professional and patient or woman interaction is reciprocal. So this means that the health worker also gains as well as the woman. So we've just published a paper in the Lancet Primary Care, which has actually looked at how relational care does contribute. And the paper was called Every Contact Counts. And the reason for this is I'm sure that everybody here can recall a good healthcare provider that they've met, And you can also recall, one that hasn't given you the satisfactory experience that you expected. And what we're arguing within this paper is that every time a woman meets a midwife, whether it's for 5 minutes, 10 minutes, or an hour, that contact has to count. She has to go away feeling that she had a good experience. But also, the health provider needs to feel that she's also provided a good experience as well. It's got to be mutually beneficial, and that's what relational care is about. We know that people vote with their feet. So if you go to a midwife and she's not very kind to you, well, you're going to try and avoid that midwife next time. And sometimes, particularly in low middle income countries, they might avoid going completely. They might decide not to go to get any antenatal care, for example. We know that relational care supports quality care by emphasising that mutuality of trust, effective two-way communications, and also shared decision making. So people often get a little bit tied up with the definitions and use various definitions interchangeably. So relational care, person-centred care, respectful care, and continuity of carer. And they do all have similarities. But what we all aspire to is probably continuity of carer, where we have the same midwife or the same group of midwives giving the same care throughout the maternity continuum. And this is this here. But it's not always possible to have continuity of carer, particularly in some of the least resourced places. But what we can have is relational care. And the important thing here is this bi-directional interplay. So if you have relational care, you can still have person-centred care, you can still have respectful care, and you can have mutual benefit, but it might not be the same people. So it's like every contact counts. So just so that we're clear on those definitions. So this is the kind of philosophy that's underpinned a lot of the work that we have conducted within our centre. So going back to some of the research, we were fortunate enough to be awarded a 4-year programme, NHR Global Health Research Group on stillbirth prevention and management. And this was one of the areas that the Lagina African Midwives Research Network prioritised. And this programme was really to conduct a lot of exploratory work, looking at some of the factors, but not just the disease focus. We were looking at the social, cultural, economic factors. And this was really important because what we didn't want to do was just to transpose what we do in high income countries into low middle income countries without first doing the groundwork. This was really, really important to us. I'm not going to spend a lot of time on this particular programme, but just to say that from this programme, even though it was exploratory, we got a lot of impact out of it. So in terms of individuals, in Tanzania, all women following stillbirth are now seen by an obstetrician. They weren't previously, they are now. In Kenya, babies were kept in babies that had died were kept in a box under the bed. Now that's changed, the sites that we were working in, there's a baby viewing area, a separate room, and a counsellor for women following stillbirth. In Zimbabwe, they introduced a clinic called the Tembani Clinic. So Tembani means hope. And the idea is that this clinic is for women who'd had a stillbirth and then had a subsequent pregnancy, so that they could get specialist care, they could get scans, they could get counselling, and lots more support than they were getting. In Malawi, we found that the fetal heart was not being listened to prior to cesarean section. This is now happening. And in Zambia, they had a real problem with the lack of privacy, but curtains are now being provided for women. We had system impacts as well in terms of integrating community engagement with a sustainability strategy, increased research and clinical capacity, and we've developed sustainable healthcare worker training packages. We also managed to inform policy in terms of national stillbirth audits, inquiries and guidelines. So even though it was exploratory, we did manage to do quite a lot. So this programme, this 4-year programme, then led us to the programme that we're just completing now, which is a 5-year programme. And this is an NHR Global Health Research Unit on prevention and management of stillbirth and neonatal death in sub-Saharan Africa and South Asia. So we expanded our scope to include neonatal deaths, which we weren't previously. And we also added countries from South Asia. So we now have 8 countries that we're working with. And these studies were more definitive evaluations following on from the evaluation work that we conducted. And we had 3 main objectives. One was to determine the best way to reduce the number of stillbirths and neonatal deaths. Secondly, to determine how best to support women and families who experience a stillbirth or neonatal death. And then also to develop the research capacity and mechanisms of knowledge transfer with particular emphasis on midwives and nurses, because we felt that they were untapped resource, but were best placed in order to conduct meaningful research. So these are the settings that we've been working for the last 5 years. So the 6 countries that I mentioned previously, and also Pakistan and India. And you can see the stillbirth and the neonatal death numbers, and you can look and compare them to the UK as well. So within this programme, we looked at the whole continuum of maternity care, starting from the bottom going up. So these were problems and issues that were identified throughout our previous work. So we conducted a trial. It was a cluster randomised trial looking at a Panda mobile health app to improve antenatal attendance. We developed a respectful care bundle, and I'll talk about that a little bit more shortly. We conducted work on adolescent maternity experiences, some feasibility work on parental involvement in care of the sick baby. We did a study, a participatory action research study looking at implementation of the World Health Organization intrapartum guidelines. We evaluated a bereavement care package in a large study in Uganda and Kenya. And we also did some work on postnatal peer support for women who had a fistula and a stillbirth. But I'm going to focus a little bit more on the respectful care bundle shortly. But what really unites all of these different work packages is the issue around relational and respectful care, as well as the intent to improve outcomes and experiences and to strengthen the capacity of those involved. So if we look at the respectful care study, and this was a mixed method study in Malawi and Tanzania. And why we did this study was that we knew that disrespectful care has a detrimental effect on women's childbirth experiences and discourages them from seeking care at health facilities. It reported a lot more related to low and middle income countries, but it's certainly not unique to low and middle income countries. You know, there are reports of disrespect and abuse elsewhere. We found that there was a lot of papers describing respectful care and how bad it was, but there was less papers reporting research that looked at preventative interventions. And although dogs kicking off there, although systematic reviews offer insight into important respectful care components, these have been inconclusive. So what we did was we aimed to determine whether implementation of a sustainable respectful care bundle decreases women-reported episodes of disrespectful care. What we mean by a bundle is a group of interventions that are all implemented at the same time. As I said, we conducted it in Malawi and Tanzania, and we had 6 linked facilities, 3 in Malawi and 3 in Tanzania. And this was a 3-phase study using interrupted time series. So that basically means that we're looking at the trends in the data before and after and during implementation of the intervention. So we developed our intervention using various forms. So we had interviews, focus groups, community surveys, and also observations. And this information then informed a consensus meeting. We used an approach which is called nominal group technique. And basically that is just a really good technique that makes sure that everybody's voice is heard. So this led to the intervention being developed, and then we optimized the actual intervention in a site before subjecting it to other sites for evaluation. So I just want to tell you some of the things that the women were saying before the intervention, just so that you get a feel for the type of things that were happening. So health workers should not use abusive language when providing care to women with unpleasant appearance. And this was about discrimination. Sometimes they examine a person when they're big in numbers, and then you may see that all of them are men. And what this was about was people being examined, and then they would look up and they'd find that there was like 20 medical students surrounded around them. The privacy is not enough, because if a person passes by, they can see you, and the explanation given to someone is heard by everyone in the labour ward. So that was about physical and verbal confidentiality. When we are here, phones are not permitted, so it's not possible to tell someone when you give birth or if an operation is needed for delivery. So they had no communication with their relatives who were not allowed to accompany them for the birth. Midwives should seek consent when performing activities. They should just not arrive and say, we want to test you. They just insert their fingers and you're surprised. So this is obviously about vaginal examinations. The doctor should take care of me. He should talk well, not shouting and not intimidating. So this was just a collection of the type of things that women were telling us. Midwives are harsh. Sometimes they hiss and slap you. And when we interview the health workers, sometimes we overlook this right of confidentiality. And when a woman delivers, you often start talking about participants' information in front of colleagues and guardians. I've been practicing as a midwife for 13 years, but I've never attended a respectful care training. And when ... this was the doctor's name, comes, he was like the disciplinary committee of labour ward, and that one actually gives slaps and changes needed. I think we need to change our attitude towards our clients, how we talk to them, how we handle them. We need to change. So this was some of the premise in which we developed our bundle. And this was our bundle. Well, it is our bundle. It's ongoing. So you can see that there are certain elements here. So the whole bundle is informed by appreciative inquiry. And this is a positive organisational approach, which basically builds on what's good in that organisation rather than trying to problem solve. We also use the combi model for behaviour change, because we know that training alone is not going to make a difference. There needs to be behaviour change. So we did do training and mentorship and respectful care, and this was informed by the behaviour techniques. We had supportive leadership training, mentorship and self-assessment. We also tackled the lack of privacy and verbal confidentiality by using screens, securing files so nobody could just pick them up and look at them, limiting the number of clinical observers, having areas for confidential discussions, and also giving training on issues like consent, for example. One of the big things within this bundle, and I personally believe this is one of the factors that's really made a difference, was the the component of valuing staff. And we did small things that made a huge difference. So we provided tea and coffee and made sure that staff actually got breaks. Honoured annual leave, which wasn't happening. We had Employer of the Month, peer appreciation boards, so that anybody could appreciate anybody, whoever they were. Music in the labour ward. In one of the labour wards, they actually danced and sang at the beginning of a shift so that people could just forget all the problems from home and just start again feeling fresh. Staff counsellor, and in some of the sites, they celebrated good practice on a monthly basis. We also had community engagement and involvement, which was central to everything that we did. And this related to advocacy, informing women of their rights, through various mediums like radio, pamphlets, etc. And we had respectful care champions, which were within the facilities so they could help the implementation as well as advise the research team. So this was our bundle, nothing dramatic, all very small things, but these were things that mattered. And then we evaluated the bundle, both before, during and after, through various means, interviews, survey, job satisfaction survey, the interrupted time series. And the interrupted time series, the way we collected the data was through these Smiley survey terminals. And I'm sure you've all probably seen these, maybe not in research, but I'm sure you've seen them in public spaces. We often have them in public toilets and also in airports. And basically, the woman, as she was leaving the facility, would hover over the smiley that both best represented her experience after being given some instruction by the research assistants. And she would do it on the way out of the exit of the facility. So there was no chance of anybody looking and saying, oh, what are you doing there? We also collect logbooks and clinical data, and we did a cost analysis too. And these are the community survey results. So if you look down the first column, you can see that physical abuse actually fell from 15% to 1%. Verbal abuse dropped from 46% to 10%. Stigma dropped from 15 to 0.6%. Privacy or lack of privacy dropped from 60% to 29%. So this was really good. Privacy is perhaps not good enough, but going in the right direction. And what was particularly interesting was that 3 of the sites didn't have any verbal abuse at all after the study had finished. We also asked 2 additional questions in the community survey. Would you choose the same hospital again, as that's always a good test? And we found that that increased from 60% to more than 90%. And would you recommend the hospital to a friend? And again, you can see from the bar chart that that also increased. So looking at the Smiley survey data, and you can see a woman here pressing the button, we asked 1 question. How do you feel about the maternity care that you and your baby received? And we did this over a 108-week period, and we were basically interested in the non-green buttons. So those buttons where people were not very happy. And bear with me on this one, it looks complicated, but it's actually not. So these 2 lines represent the trends, and they estimate, the green line estimates the trend, and any changes represent external factors. And the blue line also estimates the trend, but this assumes that any factors are actually due to the intervention. And that's a very simplified way of explaining it to you. And what's important is that in the stable period, there was actually a significant difference. So there was a significant reduction in women reporting disrespectful care. And what was even more reassuring was that this continued in the sustainability period and actually even got better without our active input. So whatever we did had triggered a response. So coming to the job satisfaction, and within our study, we included all health workers, whether they were nurses and midwives, doctors, clinicians, hospital attendants, cleaners, guards, etc. And we used a Likert scale that had been used previously in Ethiopia. And you can see here some of the activities that were going on with staff appreciation The bottom right one, you might not be able to detect what it is, but they were just getting a whole batch of tea, coffee and sugar delivered, and we're very happy about that. So this is the staff survey results. And you can see for most of these domains that the post-implementation, the blue lines, that the staff were more satisfied in all these different things. The ones that we didn't make a difference was ease of job, but our bundle wasn't it wasn't developed to do that. So that was, we weren't expecting to have any change there. The one that's a little bit more confusing is perhaps encouraged by supervisors, because this actually went in the wrong direction. And we don't know whether the question might have been misinterpreted or whether that is a true result, but it's something that we haven't really been able to discover what that result meant. We also found that pre-implementation, we were getting comments like positive feedback to staff is needed when they've done well. We need to be motivated, you know, and they gave us suggestions on how to do that. But post-implementation, they talked about, we've seen improvements in patient satisfaction, staff morale, clinical outcomes. For example, after launching the Best Midwife of the Month programme, there's been increased collaboration among team members and a shared commitment to delivering compassionate care. And the hospitals actually found that the number of complaints dropped dramatically, which was an outcome we weren't particularly looking at, but they did record. So what we concluded from this research was that clear improvements in women's care provision were observed during and following implementation of the bundle. Staff reported feeling valued post-intervention, valuing health workers motivated them to provide better care. And this was supported by the qualitative data, which I haven't got time to show you. There does need to be a commitment to sustain the bundle and address gaps, and we are actually doing that both in Malawi and Tanzania and Zanzibar, where we're rolling it out. And our economics show that the cost of the bundle implementation is actually less than $2 per birth. And this would drop substantially as time went on, because things like the screens and curtains and things have already been provided for, so fairly cheap. So I think that this work actually shows that relational care is possible, and we had lots of feedback on the good relational care. But I just want to draw your attention to Maslow's hierarchy, which I'm sure that many of you did even when you were at school. Anybody not know Maslow's hierarchy in the room? No? So the hierarchy is a pyramid, and it starts at the bottom and goes up. And what Maslow stated was that you have to meet the needs at the bottom rung before they can go on to the next rung, and then the next rung, and so on. So at the bottom is the physiological needs. And you can see that both women and health providers need these needs. So if they're not being met, then they can't move on to the next level. Safety needs, so in the women, protecting the baby and the self. Love and belonging is about inclusion, relationships with the health provider, family support. Esteem, respecting oneself and respecting others and being respected by others. And only when these things happen can you have self-actualization, the optimum birth experience. But similarly with the health providers, and this is a bit that's often missing out of the work we do, and when we're having discussions about women's experiences, we have to look at these things hand in hand. So the midwife needs to feel that she's safe. She needs to work in a facility with adequate resources, policies and autonomy. She needs to feel valued and supported within the facility. She has cognitive needs. She needs to reach her potential. She needs to be using her skills, and she needs to have self-awareness as well. She needs to be respected and to respect others. And only then will she get job satisfaction. And perhaps it's only then she can truly put the women's needs first, when she has all these other things that she's worrying about. So I think we really do need to look at these side by side. And just to look very briefly at the World Health Organization's maternal framework. They do acknowledge provision of care and experience of care, and they do acknowledge effective communication, respect, and preservation of dignity. But what I've added to this is valuing staff. I think that is missing from this. And I also think we need to go one step further and have relational care. Andrew, you'll be pleased I'm nearly finished. So in terms of the in terms of discussion, just some points for consideration. So I think that regardless of setting, resources, care model, relational care is possible. I think it's much more than continuity of carer. It's a positive encounter at each contact, and all parties, so health workers too, gain from the experience. I think overcoming barriers to relational care can be cost neutral. And I don't think we should use resources to justify transactional care or disrespectful care. I think an appreciative inquiry approach where we value positive behaviours should be considered. And this approach benefits healthcare recipients, health workers, and the organisation. So final words. Women and health workers' experiences are critical to delivering impactful healthcare, and relational care is paramount to this. And final words is that we can't do any of this without the support of women. It makes no sense to fight for midwifery if women don't want it, and women need to know that midwifery exists. They need to want it and they need to demand it. And this was something that Rose Malay said to me, and it's actually referenced on the web as well. So I start with Rose Malay and I end with Rose Malay. And thank you all for listening. And these are my points.
Brilliant. Thank you so much, Tina. Fascinating. Is this somebody just... So, questions? Questions in the room, first of all. You get a chance first off, and then we'll move to anyone online. Yeah, please.
Well, I'm very practicing midwife, but good work for what you've done in the sub-Saharan countries. Well, my question is, you put all these things into place. When do you go back to actually monitor them that they're still going well?
Yeah, no, that's a really good question, and sustainability is always an issue. But we finished the 6 sites over a year ago, and we have been back to them. And not only have they carried on with the intervention, but they've added more things and they've lobbied for additional things to add to that respectful bundle. And I think they've really recognised the fact that look after each other, and that will also transpose into looking after the women as well. So yeah, it is being sustained at the moment as far as we know.
Ethical ambulance, how do they work?
Okay, so it's only so this was a study in Malawi, and they couldn't get from the rural village to the facility. There was no transport, and the cars and trucks couldn't access it. So it was basically a bike that's got like like the kind of tourist type ones. It's got like seats at the back, well, like a little bit longer, and the women sit in the back, and that made a huge difference to the time that women got from the rural villages to the central facility. Thanks, Ronnie, for the questions.
Thank you. Other questions? Maybe let me take one online, because there's somebody talking about the implications for the UK, and especially about the respectful care bundle. And it's true, we're hearing a lot about birth trauma in the UK, and I guess are these the same, or are they not? They're degrees, but how much can we learn from the lessons of your respectful care bundle to implement it here? Do we need to start again doing all the focus groups and all the appreciative inquiry and all that to start with? Because it looks like a bundle which could work very well in the UK.
Yeah, I mean, that's a really good question. So just to say that we are looking at doing it in the UK, and in fact Tracy is leading a grant application at the moment that's been shortlisted to take our learnings from Tanzania and Malawi and using some of the Tanzania team to act as consultants on that project. And, you know, I'm pleased to say that Tracy's grant was shortlisted. So we're now working on the second stage, and we're hoping to be doing that in Lancashire, in Manchester and in Liverpool. But the other part of the question, I suppose, is do we have to start again? I think we're going in with some learnings. We'll have to do some preliminary work, but I don't think we'll need to do as much as what we did starting off, because we know a lot and there is a lot of resonance between women, midwives, you know, regardless of the context. But obviously it'll have to be adapted accordingly.
But clearly, because the principles of what were they, training, leadership, privacy, and valuing staff actually are, they're sort of universal, aren't they? And you can tweak exactly what's needed within each of those, but those are completely recognisable to me as somebody who works within the National Health Service.
Yeah, I think, you know, the components of it will be pretty much unchanged. It will be the nuances within those components that we would adapt accordingly. Yeah.
Yeah, I'm just having a look because there's more conversation online then about the importance of this very same principles of midwifery care and how important they are here. Other questions, other comments, or? Yes, please.
Hi. Thank
Good
you
evening.
very much, Mr. Tina. My name is Motam Melestian, and I've just been looking. Thank you first of all for the presentation and the massive amount of work that is being done right now. I'm just trying to reflect on the aspects of implementation research, where we are basically looking at, you know, trying to enable what is known to function well to actually be put in place where it's needed. But my experience with some of these implementation activities is that there are often pushbacks. And especially when it comes to healthcare practice, in domains like midwifery, there's often pushback from people who are comfortable with the status quo. And in my little experience, it often comes from doctors.
Yeah.
So while, by the way, I'm a doctor, I'm not a hospital. And we have that impression that hierarchy puts doctors at the top, whereas we all have different roles and we have to contribute equitably within the health system. So in your case, how were you able to navigate such pushbacks, or what were some of the challenges that you found that would help someone like me be able to navigate my own terrain in terms of implementing certain, you know, simple measures like this to create change in hospital health context?
Yeah, can we just repeat the question for those online, because they won't have heard online? Maybe I can summarise that there is a question from a colleague at School of Tropical Medicine saying that there's powerful hierarchies often between doctors and midwives, nurses, and some of these things challenge those hierarchies and it's difficult to get buy-in. And in fact, people are sometimes very happy with the status quo. How did you navigate all that?
Yeah, I mean, I agree that sometimes it can be challenging, but we've worked quite a lot with these partners, so that's one good thing. When we first started off, I don't think we did have the buy-in the same, but we set up stakeholder groups that contained, you know, the Ministry of Health, the various NGOs, the doctors, the administration, as well as the midwives. We also made sure that our work aligned with the national priorities as well. And we've had ministry involvement, you know, from the word go, and I think that is a key thing in some of these countries. And I think that we've demonstrated over the years that we can actually do things that your ministries would like you to do, and we can help you to do that. And I would say that we have a huge amount of support from the medical colleagues in all of these countries, in all of these sites. I think the other thing is that historically, it's been unusual for midwives to lead large programs. So I actually think, and I know that there's at least one that's online now, I think Rose Lacer would confirm that, is that historically midwives didn't lead these programs, and then the people are starting to lead these programs and bring in large amounts of money, and then some of the doctors and other stakeholders are looking up saying, oh gosh, you know, Rose has just brought in more than £1 million, you know, maybe we need to collaborate with her, you know. So there's lots of different things really, but I would say it takes time also, but happy to, I mean, obviously I'm at LST, I'm happy to chat to you and tell you some of the other things that we've done.
Brilliant, thank you. Just seeing, I think there was a question online, but that's somebody raising their hand unusually, but somebody saying online that they work in the NEST team in Liverpool, the non-English speaking team, and how actually this is very relatable and has brought a really important dimension to them of how they perform their care. Terry.
That's a difficult question. It's more about thinking to the future. If you were able, hopefully, the spectrum bundle be implemented in the UK, do you think it will have an impact on racism within the NHS? Because so much of that is grounded in disrespect, isn't it, and abuse?
Yeah, no, absolutely, Terry. I mean, I think discrimination was one of the components of the training, definitely, and yeah, I think it could do.
Is there any way that you'll be able to measure that change so that it can be highlighted in practice within some reports and things like that?
You know, that's a really interesting point. I don't think we thought about that. I'm looking at Tracy now, but yeah, maybe.
Sorry.
Yes, no. Go ahead.
I think in the grant, because we'll be doing a similar type of design, we will be able to analyse subgroups, because we're trying to cast the net as wide as, you know, and get as much spot, you know, trying to make sort of the way of collecting data a little bit inspired by the Smiley surveys. You know, you get a data from a lot of people, and if you get a little bit of demographic data, then you're able to make, you know, some inferences across different groups. So we'll try. But it's a very good suggestion, maybe to emphasise it a bit more.
Yeah, no, it is a good suggestion. Thanks for that, Terry.
Can I ask something then? The brain drain in Liverpool and across the NHS, we gain a huge amount from midwives coming from especially from Tanzania, Uganda, Zimbabwe, and we find real brilliance there. And yet there's always this feeling that actually we're doing the home service a disservice by midwives being trained, a lot of money being put into their training, and then somehow we go out and recruit from the UK, which is huge benefit from us. We love it, and it really helps with our racism agenda, etc. And yet you can't help feeling we're doing a disservice. Have you any sense of how we deal with that? It seems very difficult.
Yeah, no, I agree, and it does feel very uncomfortable actually, especially when you visit these sites and they're so short-sighted, and you know, and they, you know, some of the sites will say to you, you know, all our midwives and nurses are going to the UK and, you know, and other European countries, and that feels really uncomfortable. I know that several years ago they put a ban on it because it was getting out of hand, and you know, less midwives, you know, increased mortality and morbidity. So I don't know how we solve it, Andrew, is the honest answer. I don't know what we do. It needs to be solved, you know, high up, doesn't it? It needs, you know, policies and guidance. It's not something that you and I will ever solve, I don't think, although we can lobby for it.
Well, I mean, I'd always assumed that there'd be a system where every midwife you take out of a system, you would pay for 1 or 2 to be retrained, and that would be part of the deal. but it doesn't seem so. It seems a sort of a bit of a cowboy country out there, and whoever can recruit and attract people, then you win, and the system in the training country loses.
Exactly, and you can't blame people midwives for wanting to go and experience other places either. So it's a really difficult one. I don't know how we solve that one. Sorry.
No, if there were easy answers, we wouldn't be struggling with them. Yes.
Yeah. Really interesting point you bring out there. Last year I attended the UK Africa's Global Health Partnership Summit, and this was a really interesting topic of discussion there on how do you encourage people to support their countries of heritage, even if they've moved into other countries. And I think some countries like Ghana and Kenya have been creating some really interesting partnerships, tracking health workers and health providers who leave their countries and trying to encourage them to engage themselves in, probably not fully combat, but engage themselves in various activities that could lead to providing support or some form of assistance, or let me use the word assistance, some form of give back to the countries of heritage, where they've come from. And one key point that came up from that discussion was that this has to be a proactive team by the recruiting institutions in the UK to be able to support such programs, because a lot of those programs were actually self-funded. So when these countries or these governments get in touch with these people, they would self-fund a lot of activities to support their countries of heritage. So I think that we need to look into some bits of institutional funding for people who come from such places to support their engagement activities when they get back to some of their countries of heritage.
Thank you. Any comments on that, Tina?
No, just really good suggestions. Yes, absolutely agree.
Okie doke. Yes, Roger.
Is it possible to engage the Commonwealth in some sort of midwife exchange scheme?
Yeah, I mean,
so that the staff aren't pulled out of one country without there being other staff ever put back, say, from this country.
Yeah, the Commonwealth are actively engaged in maternal and newborn health. They don't seem to have a lot of resources. It's my experience of them. But I think maybe it needs to be a united thing, so that different, powerful organisations get together, not just the Commonwealth, but maybe, WHO and others that can really advocate for something to happen, those with funding and those with power as well.
The big question, it's not just about nurses and midwives. Think about how many physicians have gone to other countries. And there's a bit more equity now. Midwives were professionals, were trained to international standards. So of course people want to have a better future for their families, and that's why people move. It's for their families, just like everyone else. And I think it's not just about nursing and midwifery, it's about how we provide universal health coverage and equity within that for all health workers and for the people who we provide care for.
It's interesting, there's been a scheme for doctors called MTI, which has brought doctors for training from overseas, and there were 40 obstetricians and gynecologists a year who came, and that scheme's just been stopped just within the last couple of months. And one of the arguments put forward was that this is that actually the MTI doctors actually were brilliant, because they, of course, you select globally, you take the very top doctors from around the world, and they come here, do brilliant work, and everyone goes, oh, we really rather like this person to come and be a consultant to our unit, and they're recruited internationally and stay, which is brilliant for the receiving country. It's great for maybe that doctor, but the original training institution has had their top doctors screamed off. So this discussion will run and run. I see we're after 7 o'clock, so I think we should finish here. I think there's yeah, no, that's all right. I think we're okay. There's interesting chatter online, but thank you so much, Tina. Very much appreciated. We have a small token of our appreciation, which is an LMI medal, which I'd like to present to you. Thank you so much for giving one of the key talks, actually, of the year as we come towards the end of this Bringing Life series. Thank you so much. So next up is in 3 weeks' time. Then on the 18th of June, we have our final lecture of the series, and the members will be maybe relieved that the maternity and the midwifery theme, which they've been inundated with over the last year, is coming to an end. But we have the final talk then, which is Alex Heasel, as I said earlier, who is talking about UK maternity services, a vision for the future. And that'll be at 6 till 7 in 3 weeks' time, which is the 18th of June. Before that, there's the annual general meeting between 5 and 6, which will be held here as well. So you're all very welcome. Members get a vote. I'm assuming everyone here is a member, because everyone can be members and it's relatively low cost. If you're not, then please come and join us. Be part of this and have your input into it. The membership is open to all. £50 a year, which, okay, is a lot, but actually for use of such a fantastic library, fantastic meeting rooms, wonderful institution to be part of. Come and join us. And make this institution back into the centre of Liverpool health infrastructure. So thank you very much all for attending. Thank you to the, what do we have, 27 online. Thank you very much everyone for attending. Come and join us again in 3 weeks' time. If you go to the LMI website, then the links are all there to come and join or to book. So thank you very much.